So one of the biggest unmet needs in bladder cancer is ensuring definitive therapies delivered to patients with life-threatening disease and optimizing outcome from definitive therapy. If you look at the trajectory of population growth over the next few decades, the next decade, I would say the largest growth is projected in patients or people over 65 and 70 years old. A couple of decades later, the largest growth will be in the octogenarian patient population. And this is quite relevant because bladder cancer peaks in its 8 decades. And we're going to be seeing many, many patients with bladder cancer inflicted at a later stage of life. The standard of care for muscle-invasive disease has been a radical cystectomy, removing the bladder and performing urinary diversion, along with perioperative chemotherapy. Bladder preservation is an alternative therapy, particularly trimodality therapy, which is combining chemotherapy and radiation, which works well in properly selected patient population. It's important to highlight that chronological age alone should not be used to exclude patients from radical cystectomy or other definitive treatment options. Appropriate treatment options, appropriate treatment decisions should incorporate functional status of the patient and comorbidities, as well as the patient desires and goals. If you look at the trajectory of the patient across the spectrum, after getting a bladder scraping and being diagnosed with muscle-invasive disease, as I said, they can either go through cystectomy or trimodality therapy in appropriate patients. And the concern is the significant number of patients that may not receive any definitive therapy in North America. If we examine several studies, and I'm quoting these ones from the States, and I'll talk about some numbers from Canada as well, but several studies from the States. This is the first study looked at a few years ago, showing that in the SEER database, the majority of what we call octogenarian patient population diagnosed with muscle-invasive bladder cancer, they do not receive any form of definitive therapy, 60%. Another study looking at another population in the States, similar results. The majority of patients in their 80s don't receive any form of definitive therapy. We're not far better here in Canada. If you look at the Ontario outcome experience, the majority of patients who die of bladder cancer never received definitive therapy to their bladder in the past. And why is that so? I think a large part of the reason is in the approach of muscle-invasive bladder cancer. What's commonly done, if the patient is too sick to undergo a radical cystectomy, they're often not receiving or offered any other therapy at all. We do know that trimodality therapy can be well tolerated in many patients that are too sick to receive a radical cystectomy. Trimodality therapy has gained widespread acceptance in patients who are not surgical candidates or refuse cystectomy. The outcomes are comparable in properly selected patient population. And what's important is many patients who are not surgical candidates can tolerate this form of therapy for muscle-invasive bladder cancer. There's 2 approaches to this. One is giving the entire radiation and chemotherapy up front and evaluating response after, or giving what we call an induction course of radiation chemotherapy. Evaluate response, and if there is a good response, then give the complete course. The radiation is given to the bladder and lymph nodes, and what's important is to add chemotherapy to that, because what chemotherapy does is increases the efficacy of the radiation and improves outcome. Factors associated with favorable oncological outcome of trimodality therapy are smaller tumors, if you're able to remove most of the tumor, if there is no blockage of the kidney or there's no hydronephrosis, and if there's no diffuse disease in the bladder. So again, patient selection is key, and this option should be offered to patients, particularly if patients are not able to tolerate surgery. The second important thing is optimizing outcome of definitive therapy, and I think this is the low-hanging fruit. We do know that bladder cancer is the second most common smoking-related cancers. Approximately 50% of bladder cancer is attributed to smoking, 4 times higher in smokers, twice higher in former smokers compared to never smokers. Smoking is not only associated with development of bladder cancer, but also with prognosis. Patients who quit smoking have a lower risk of recurrence and have a lower risk of developing other smoking-related cancers. Patients and physicians should be more proactive and concentrate on smoking cessation as an important component of the treatment strategy.